uric acid. But more recently, uh, we have been uh, we have been using the levels around 8, 8.5 as a target for the treatment of hyperuricemia in patients with CKD. And invariably, we see and observe that there is improvement in the I think we need certain values in our patients, uh, which are the normal for them. We don't want to overtreat them, and we do not want to, leave them without treatment because CKD patients are undergoing stress from all sides, and uric acid being one of the metabolic stresses, and that can lead to further injury into the tubules and in the interstitium, leading to chronic interstitial disease, which is already there. So I think to address all these things, we have been discussing for quite some time now, and I think it's time for action, and for which I think PharmEvo is going into the right direction. And since the chapters have been made, and we should just proceed for our epidemiological studies and most likely interventional studies, or even just retrospective studies in our patients where we have been treating in different populations and how it is helping. Thank you very much.
Thank you, sir. Can we have anyone else? Dr. Amna, if you want to comment. Dr. Farhan Ali, if you are present, please do comment. Or should I go to the ending of this session?
Hello.
Thank you. Yes, ma'am, please. I guess that's it. And since we have to start our another session of hyperuricemia updates with our other audience, and I would like to pay thanks to all of you. And we are looking forward to meet in December or January again, somewhere around January, so that we can review the progress of our Hyperuricemia Advisory Council committee that we have developed. And meanwhile, we would be pursuing local trials here, like Professor Khalid Mahmood has already started a trial, and we are hoping Dr. Anita Haroon would be again starting a trial with the prevalence of hyperuricemia in CKD patients, and we are looking forward to have trials on prevalence of hyperuricemia in diabetic patients and cardiovascular disease related patients. So Austin, thank you once again, and you need to hold as we have to start another session, and I would request say goodbye to all of you, and we would start another session. Thank you very much.
Thank you very much.
Assalamu alaikum, respected doctors and dear audience and our honorable speaker. I'm Dr. Anita Haroon, a consultant nephrologist and working as an assistant professor, Bakai Medical University, Karachi. On the behalf of PharmEvo, I will welcome you all at the 7th International Hyperuricemia Summit Conference. As we all know that PharmEvo always remain on the forefront of the academic activities, both nationally and internationally, and inspiration towards its vision and continuing its legacy. PharmEvo has arranged this 7th International Hyperuricemia Summit with the aim to highlight the facts and evidence in favor of treating hyperuricemia and the comorbidities associated with it, and seek global perspective. Hyperuricemia Advisory Council purposeful social development initiatives and ethical marketing approach reflect our commitment to the betterment of doctors, healthcare professionals, medical institutions, and all the key stakeholders. Moving forward, I would like to give the brief discussion about our speakers and expert of today's session. I would like to introduce Professor Dr. Austin G. Stack. We honor to introduce Professor Austin G. Stack, a luminary in the field of medicine and nephrology, holding an MD and an MSc, and as a fellow of the Royal College of Physicians of Ireland. His credentials are nothing short of exceptional. As the professor and foundation chair of medicine at the Graduate Entry Medical School, University of Limerick, and a consultant nephrologist at University Hospital Limerick, Ireland, Professor Stack has been at the forefront of pioneering advancement in healthcare. Today, Professor Stack will enlighten us on emerging clinical trends and advancement in hyperuricemia management. His profound knowledge and extensive experience in the field promise to provide a deep understanding of this critical subject. We also have our worthy panelist, Mr. Dr. Yudana Rathantla, and I would like to give his short introduction. We are privileged to welcome Dr. Yudana Rathantla, an illustrious figure in the field of nephrology, to share his expertise and insights. Dr. Rathantla's distinguished academic background, including an MBBS and Doctor of Medicine from Colombo, MRCP UK, MRCP Nephrology, and a DIP UK Med from Liverpool, reflects his commitment to medical excellence. As a consultant nephrologist and a fellow of the Royal Infirmary of Edinburgh, UK, he has honored his expertise through hands-on experience. Notably, Dr. Rathantla's leadership roles as a current secretary of the Sri Lanka Society of Nephrology and his contribution to renal care publications exemplify his dedication to advancing the field. Now, I would like to move further, and I would like to invite our worthy speaker, Professor Austin G. Stack, to give his talk today. Over to you, Professor Stack.
Good morning, everyone, and thank you very much for the invitation. First of all, I hope you can hear me and see me. That's always a good thing. And let me just see, can I share my slides at first of all, and you can tell me if you can see them. So we will start. Can you see the slide set?
Yes, we can see.
That's fantastic. So good morning, everyone, and thanks to PharmEvo for inviting me to speak this morning on, I think, a hugely important topic and a growing topic that I think has challenged us over the past 50 to 60 years. And just to kind of set the scene and highlight some debate and controversy, I've titled this Hyperuricemia. Is it a metabolic mediator? Is it a risk marker or a risk factor for disease or for chronic disease? And many of us feel it may be all three, both a mediator, both a risk marker, and indeed a true causal risk factor for many of the diseases we see in this century. Again, just a thank you to PharmEvo, who I think have been at the forefront in terms of medical education in Pakistan, I suppose pushing the frontier in terms of hyperuricemia and gout, and supporting the mission of better understanding, better science in terms of how we manage patients with elevated uric acid levels. And earlier this morning, we had a very brief meeting on the development of guidelines, which I think will be of value for all practicing clinicians in Pakistan. And I look forward to that program developing over the next year or so. And this is just a photo of the summit in 2017. I think the first summit was in 2015. the second in 2017. And I think I'm the only one who's aging there. Everybody else still looks so young. So I'm going to start with a kind of a slide and a question. And I think this is important, and it's part of our clinical practice. And the question I have for you is how should we manage this patient here? And just to set the scene, this is a 50-year-old man with existing type 2 diabetes and hypertension, and he has a panel of bloods performed. It shows, I know it's in SI units. He's got an elevated cholesterol, total cholesterol, an elevated LDL cholesterol, an elevated uric acid, and a modestly elevated CRP. So how would we treat that? And I think many of us would say, in terms of hyperlipidemia, hypercholesterolemia, we need to treat this man aggressively, given his overall global risk of cardiovascular events. But there might be debate in terms of uric acid. Is this value a high value? And just to kind of convert it to milligrams per deciliter, this is over 9 milligrams per deciliter in terms of plasma or serum uric acid. So what would your treatment be for this? Would it be no treatment? Should we treat? Should it be lifestyle modification? Does he need a uric lowering drug? And what should the target be? So I'll let you ponder on that as we discuss what we think the evidence base is over the next 40 minutes. So when I think of hyperuricemia, I think of the major disease categories that this risk marker or risk factor is related to. It's certainly causally related to gout, and it's the predominant causal risk factor for one of the most common inflammatory conditions in humans. And this is the patient I just saw recently, again, quite bad chronic tophaceous gout with an acute monoarthritis, an acute tophi there with kind of a active, quite painful inflammation. There is a strong body of evidence linking it to kidney disease, both in terms of biologic plausibility and epidemiologically, and clearly from my nephrologist perspective, we'd like to stem the tide of chronic kidney disease and dialysis. So that's another major disease. And finally, it is linked to many other lifestyle and metabolic disease, including diabetes and cardiovascular disease. So these are kind of major disease categories, major diseases that elevated uric acid seems to have a major pathological consequence. And again, just to kind of do not forget about gout, because it is quite common. And as we get older, it's even more common. This is a woman I saw last week in clinic who has been walking around and living for years with these progressive tophi in her hands and in her elbows. And I asked her, is this sorted? It is very tender. Now, not alone does she has, the obvious tophus, but there is an acute inflammatory reaction. And within this blister here, there's a sludge of urate crystals. And clearly, this unfortunate woman has not been managed well. And we need to do a better job in terms of care delivery. But just to get back to uric acid, so there is a large body of knowledge, a large body of evidence that is linking elevation of uric acid causally to a range of major chronic diseases. And that's why there's a huge impetus and interest in terms of getting a better understanding of the pathobiology, a better understanding of the thresholds at which we should, treat individuals, and a better understanding of treatments that are effective in reducing uric acid in order to improve patient outcomes. There are many mechanisms through which uric acid can have a deleterious effect. And we know in gout that crystal deposition is probably the predominant one, causing, an exponential inflammation due to the inflammasomes in the joints to cause both acute gout and chronic gout. And then there's a number of various pathogenic genetic mechanisms through which hyperuricemia can induce both kidney injury, vascular injury, and we talk about both direct and indirect mechanisms. There's good biological argument for a direct vascular injury, but there's also, a possibility that uric acid, through its relationship with hypertension, diabetes, and metabolic syndrome, that can also be a mechanism through which chronic kidney disease and cardiovascular disease may develop. So multiple mechanisms through which uric acid may exert a deleterious effect in humans. And I'm going to focus on just a couple of specific diseases, again, just for clarity, to show both the biological plausibility and also the epidemiological impact. And this is a study, and it again has been replicated, that hyperuricemia causes a specific damage to the kidney, a specific injury to the kidney. And in this rat model, we know that it induces blood pressure as the uric acid levels go up, and it causes fibrosis. And many of you will know that fibrosis is the end game. When you've got fibrosed organs or fibrosed kidneys, those kidneys are on the trajectory towards really chronic kidney disease, progressive CKD, and end-stage kidney disease. And similarly, hyperuricemia causes a vascular disease, and it causes a specific vascular injury with progressive narrowing of the arterioles in the kidney. And there's great correlation between the extent of hyperuricemia and the magnitude of the blood pressure rise in rat models who are exposed to significant levels of uric acid. So there is the prevailing pathophysiological mechanism through which uric acid can induce a very specific arteriolopathy and subsequent hypertension that can lead to progressive chronic kidney disease, or indeed progressive vascular damage. Of course, we can mitigate and prevent or treat that disorder if we can lower the serum uric acid or the plasma uric acid. And allopurinol, an xanthine oxidase inhibitor, can do that. And again, that's been demonstrated in the model. So if you treat with your allopurinol and there's a reduction in uric levels, it normalizes blood pressure and it reduces the magnitude of the damage in specific organs like the kidney. And similarly, febuxostat has a similar effect because it's a very potent xanthine oxidase inhibitor. And in rat models, it very clearly shows that it lowers uric acid, it normalizes blood pressure, and it reduces the extent of fibrous damage or interstitial fibrosis in the kidney. So the biological plausibility is very important, and that's, one part of the evidence base. Is there a good biological argument that uric acid can cause damage to individual organs? There's also this epidemiological evidence, which is important to understand in terms of quantifying the magnitude of hyperuricemia and also the relation with specific diseases and specific metabolic diseases. And I always like to show this slide. It's a US data based on the NHANES, that the cross-sectional study looking at the prevalence of chronic kidney disease, the milder stages 1 and 2, hypertension and obesity. And I think the ordinary person on the street can even see this, that as the serum uric acid levels increase, that we can see that the prevalence of these three common states and diseases also increase in a progressive fashion. So even patients with a uric acid between 6 and 7, 1 and 2 have CKD, a third are hypertensive, and over 40% are obese. So, there is this substantial correlation between hyperuricemia and many of these metabolic disorders or lifestyle disorders, including chronic kidney disease. And there are some nice studies that demonstrate that high levels of uric acid cause the earliest form of damage in human kidneys, and that is the leakage of albumin or microalbuminuria. And we know from this community-based cohort that individuals who've got high levels of uric acid over 7 versus less than 5 have got higher rates of microalbuminuria. It's present in men and in women. So the higher the uric acid, the greater the risk of new onset kidney damage, as evidenced by albuminuria. And there's been many studies, observational studies, both retrospective and prospective, that have shown strong correlations between high levels of uric acid and the risk of both chronic kidney disease and end-stage kidney disease. So there's this compelling body of knowledge to show or link high levels of uric acid as a predictor of chronic kidney disease. And of course, if you try and consolidate the information through pooled analysis, just looking at prospective cohorts, which is the best design construct for evaluating risk. And these studies have shown that patients with high levels of uric acid have a higher risk of new onset chronic kidney disease. And in this particular study, for every 1 milligram per deciliter higher uric acid, the risk increased by about 18%. So again, another compelling observation data. We can do the same for blood pressure. So the narrative is that if you pool studies and look at the relation between uric acid and hypertension, there's a strong relationship of a strong magnitude linking hyperuricemia with new onset hypertension. It is the same for type 2 diabetes. So again, these are chronic, common, impactful conditions in our society that has shown strong association between uric acid and development. And of course, if you look at the final outcome in terms of mortality, many of you will be familiar with a large body of observational data that correlates high levels of uric acid with both all-cause and cardiovascular mortality. This is some data from ourselves a number of years ago, looking at the LinkedIn-Haines data, 15,000 individuals followed for up to 10 years to try and quantify the association between uric acid levels and the risk of cardiovascular mortality. And I'm just going to show that what happens when you adjust for the existing conventional risk factors. If you look on the bar graphs here, these are the categories of uric acid. This category here is uric acid values of between 5 and almost 6. So what we can see is that the risk is fairly flat, but once you kind of go above a uric acid value of about 5, there's an increased risk of cardiovascular death. So there's a 33% higher risk versus those who've got a lower level of uric acid, and the risk continues to increase with higher levels. In other words, there appears to be a threshold effect. There appears to be a threshold effect above which there's a higher risk and a higher rate of cardiovascular events. And we found for every 1 milligram per deciliter higher in uric acid that the risk increased by about 15%. And again, pooled analysis have confirmed this observation. So again, compelling information. So the biological argument is strong, the epidemiological argument is strong, and then we come to, I suppose, the final piece of the puzzle in terms of, can we protect organs against the effects of high levels of uric acid? So can we protect the kidneys? Can we protect the heart? Can we reduce cardiovascular events? Can we increase life expectancies? These are the big questions that we've been asking through clinical or through intervention studies. Now, I'm just going to consolidate some of our knowledge and just kind of highlight a couple of studies beginning back about 13 years ago with this study from Gocochea, who initially suggested that if you lower uric acid with allopurinol in a randomized fashion in patients with moderate CKD, that there appears to be a protective benefit. In other words, there seems to be, first of all, individuals randomized to allopurinol had a reduction in their uric acid compared to the placebo group, but also they had a stabilization in GFR compared to those who did not get allopurinol, whose GFR dropped by about 3 mils per minute. So there's a suggestion, a very small center-based clinical study, that maybe lowering uric acid or maybe the allopurinol had a beneficial impact. And similarly, febuxostat in a small study was shown to be, again, appeared to be kidney protective or renal protective, that it led to a low rate of decline in patients who got the febuxostat versus those who did not, with a change in GFR about 6.5 mils a minute, with a very small study. These are small randomized controlled clinical trials with very small sample sizes. So in an effort to kind of consolidate the information or the evidence, a pooled analysis of randomized controlled clinical trials. And you can look at the sample size here, 700 patients. So when you pool individuals together who are enrolled in clinical trials to identify the overall magnitude impact of uric lowering therapy on kidney events, the evidence was there was an apparent protective impact or effect. In other words, patients with hyperuricemia had a reduction in their risk of death by about, or risk of kidney events by about 65%. But again, the total sample size here is relatively small by, you know, standard clinical trials in the last 5 years. But it does appear to have a beneficial effect. I think there was a number of clinical studies published over the last 5 to 7 years, which gave somewhat, you know, divergent results or inconsistent results. The FEATHER trial conducted in Japan in over 400 individuals, CKD stage 3, showed there was no real benefit of febuxostat in patients with what I would say mild to moderate CKD, no big gain in terms of reducing uric acid. But clearly there were some, you know, challenges in this particular trial. It was a very low risk population. The overall rate of decline in the placebo group was very, very low. And, you know, if you're going to do a clinical trial where the outcome is very rare and the rate of decline is very low, you need a lot of patients in that trial. So again, an underpowered clinical trial to test that underlying hypothesis. And following that, there was a couple of clinical trials published in the New England Journal, in type 1 diabetes and the CKD fix in type 2 diabetes. And again, and interestingly, showed no benefit of allopurinol in patients with CKD3. And so we have to ask questions of, well, why was there no benefit when the observational data and the biological plausibility appears to be quite strong. And again, there are some challenges or some, I suppose, threats to the validity in these clinical trials: small sample size, large dropouts, and one of the crucial things in the conduct of any randomized controlled clinical trial is to ensure that they're powered to deliver. And number two, ensuring that the intervention does get the uric acid down to or below a threshold value to deliver an effect. And again, there was a number of threats to the validity in the CKD fix that the overall power of the study was substantially reduced. And finally, we ourselves were involved in a recent clinical trial to try and test the hypothesis that an aggressive urate lowering strategy might have a beneficial impact in patients with type 2 diabetes and albuminuria. And in this clinical trial, an early phase 2 trial, we combined febuxostat, the xanthine inhibitor, with a drug called Verinurad, which is a potent uricosuric. So combining these together, we tested this in about 60 individuals with type 2 diabetes and albuminuria. We followed these patients for up to 24 weeks and to assess the extent or the benefit of this combination in reducing albuminuria. And this is what we found. I want to just take you through this slide. I think it's important that following randomization within the first week, that combination of febuxostat and Verinurad lowered the urine ACR substantially by almost 40%. The effect persisted at week 12 and then continued up to week 24. So there's a suggestion in this early phase clinical study that an aggressive urate lowering strategy might be beneficial in reducing albuminuria, which, as you know, is one of the earliest signs of chronic kidney disease. And moving then just to the heart, so that's the kidney. So some divergent results in terms of the efficacy of urate lowering strategies in protecting kidney function, some challenges or some flaws with the existing clinical trials, but then a suggestion that if you're aggressive, there might be an impact in reducing albuminuria. The second, and I won't keep you too much longer, is
हेलो अच्छा भाई वो कोई दूसरी काम कर रहा था मैं आपकी कॉल वो मैंने आपको ऑर्डर लिखा है
and the Freed clinical trial was published in 2019, conducted in Japan, and this tested the hypothesis that febuxostat in a dose escalation strategy could impact a range of important clinical outcomes, both cardiovascular and renal outcomes. In this trial, where about 500 individuals were randomized to a febuxostat arm versus a kind of a usual care arm, or which is really the placebo arm, and these patients were followed for I believe up to 2 years. The primary outcome was a very large, complex outcome of both mortality, cardiovascular events, and also kidney impairment. The drug, febuxostat, was effective in significantly lowering uric acid levels compared to the control group. And then the outcome appeared to be quite insignificant, with a 25% reduction in the composite outcome in the treatment arm versus the placebo arm, 28.7% versus 23%. So again, the Freed trial suggests in Japanese patients at high risk for cardiovascular disease, that a febuxostat-lowering urate-lowering strategy is beneficial in improving cardiorenal outcomes. And then finally, we look at another large clinical trial, the FAST trial. The reason I'm showing it this morning is that this was a trial that was mandated by the European Union to look at the potential for febuxostat in terms of cardiovascular side effects. And this was following in the footsteps of a big trial called the CARE trial, which was mandated by the FDA, published a number of years earlier. And the CARE trial suggested that febuxostat might lead to excess cardiovascular events. But the full analysis of that trial, when there was appropriate follow-up and capture of all deaths, showed there was no difference in all-cause or cardiovascular mortality between those getting febuxostat. But the FAST trial is an important trial because, first of all, it showed that there was no difference in cardiovascular mortality between individuals randomized to febuxostat versus allopurinol. But I think even more important is that the febuxostat treated arm had a significantly lower rate of all-cause death, a significantly fewer cardiovascular death events, and the hazard ratio was 0.84, that almost reached a significance for a superior effect. So again, in this trial, the FAST trial, febuxostat led or was associated with a greater reduction in mortality, all-cause mortality, versus allopurinol in a population of patients over 5,000. And this is just a comparison of FAST with CARE to show what the differences were. And I think it's important to highlight that the CARE trial had some serious flaws, and that, of course, did lead to an FDA warning. So in the CARE trial, over 50% stopped treatment in the trial, and almost half were lost to follow-up. I mean, that's incredible compared to the FAST trial, where a lower fraction stopped treatment, and just 6% were lost to follow-up. The final study I'm just going to show is the ALHEART clinical trial published in the Lancet last year, which compared allopurinol versus usual care in patients with high risk for cardiovascular events. And the final concluding, I suppose, remark about that is there was no difference in the allopurinol versus the usual care. So no benefit from allopurinol. So when we look at the evidence base, what should we do in patients who've got hyperuricemia and coexisting disease, type 2 diabetes and hypertension? I think we have to look at the evidence base from across the globe, both the biological evidence, the epidemiological evidence, and the clinical trials. And when we look and interpret the clinical trials, we have to ask the question, were those trials valid? Were they valid clinical trials? Can we utilize those to inform the guidelines? Are they credible? Were they sufficiently powered? Did they have threats to the validity? And if they do, then we really can't make decisions on those clinical trials. So this is our patient, and the question, what do we do with his high levels of uric acid? And you can say, well, we should prescribe treatment. Maybe somebody said, yes, we should. Others might say, maybe. And some people say, we don't know. But I think what we have to do as a society, and certainly the professional organizations, to develop guidelines, on the management of these patients. And many, many countries have actually begun that process. As I mentioned earlier, Japan has had guidelines in operation for many, many years. And you can see at a glance here the algorithm that they use. So individuals with the high levels of uric acid, if they have gout, they automatically get lifestyle and they go on treatment. But if they've got uric acid levels of at least 8 or higher, and they've got some complications or coexisting diseases, hypertension, kidney disease, coronary disease, these patients typically get treatment and they get, lifestyle, of course, modification and drug therapy. So these are a very specific set of guidelines. I think it helps clinicians. It guides clinicians on how to manage these individuals. So I think what they've done, they've taken the evidence base and they say, well, uric acid in the context of a high risk phenotype who've got existing cardiovascular disease, existing metabolic disease, these individuals should be treated. Is Japan alone? It appears not. So the Italian Society of Cardiology and Nephrology and Hypertension, these over the last number of years have been working very closely to develop a consensus on how should we manage patients with hyperuricemia and high cardiovascular risk. And the guidelines are published in 2021, and this is kind of a view of their management strategy. And again, not alone do they say we should treat individuals who've got a target organ damage or hypertension, but they identified threshold values that should be targeted. And they're saying less than 5 in very high risk individuals and less than 6 in the majority of individuals. So these are the Italians, professional societies who've come up with a guideline and recommendations to manage individuals with hyperuricemia and coexisting disease. And uric acid is now mentioned in gout in the European Society of Cardiology guidelines. So I think there is a movement to bring uric acid in as a major risk factor, while there is still debate from clinical trials, that is, on the extent of benefit when you prescribe a urate-lowering therapy. So just to conclude, there's certainly a large body of evidence linking uric acid to several cardiorenal metabolic diseases. The observational data in terms of association is quite strong, and many of the studies suggest a threshold effect, which is around the 5 or 6 milligrams per deciliter. We will have to be honest that clinical trials have not yielded consistent results, and that might be in part due to some inherent flaws in the existing clinical trials. The international guidelines now recommend assessment of uric acid in those high-risk phenotypes, and the treatment is recommended in select national guidelines, including guidelines from both Italy and also Japan. So as we spoke this morning, I think the management of hyperuricemia is a task for all of us. Nephrologists, cardiologists, rheumatologists, physicians in clinical practice and primary care. And I think it behoves all of us to come up with a set of guidelines that may be modified for individual countries to try and improve patient outcomes and indeed improve our care programs. So on that note, I would say thank you, and I'm happy to take any questions. This is our group here in Limerick at the University of Limerick. I'm a clinician 50% of the time and an academician the other 50%. But delighted to be with you here this morning. So thank you.
Thank you so much, Professor Austin. It was a wonderful talk. In a very short period of time, you have covered all the aspects of hyperuricemia and its association with various diseases, international guidelines, new recommendations, and evidences and studies. I would like the audience to invite for question and answer session. I would request audience to put their questions in the chat box. In the meanwhile, I would like to invite Dr. Udana Radhanpala, and we would eagerly anticipate the valuable insights he will offer drawn from his extensive qualifications and his experience. Please join us, Dr. Radhanpala, and give your comments.
Thank you very much. Hope you can hear me.
Yes, we can.
Okay, so thanks once again for inviting me. I am representing the developing world, the SAARC countries like you all. So my answer regarding uric acid will be based on my experience in developing world. So as a nephrologist, practicing nephrology in this part of the world, we should look for weapons to fight against the CKD progression. The main problem in this part of the world is high prevalence of the CKD, as well as we don't have enough renal replacement therapy. So, hemodialysis like in Ireland is not freely available in Sri Lanka or Pakistan for that matter, and transplantation programs are up and running. And I know disease donor transplantation program in Bangladesh, probably 1 or 2 cases, Pakistan, only few cases, and we have done only hundreds. So for CKD patients are running out of options in this part of the world. If they progress to end-stage renal disease, that means a certain death. Because of my dual work in Edinburgh, Aberdeen, and here, I see the differences quite well. So as a nephrologist practicing in this part of the world, I would choose weapons to my armory if there is adequate evidence. So for example, I would talk about ACE inhibitor ARB, which is fantastic. It works for us. And of course, the new drug SGL2 inhibitors. So as Dr. Austin correctly mentioned, the third drug probably we missed, which is urate lowering therapy. Probably allopurinol or febuxostat should have come to our guidelines, and that would have been our second or third weapon in the attack against the progression of kidney disease. Well, so I was also going through the guidelines and studying this case, and of course, probably my opinion changed after listening to your wonderful talk, Dr. Austin. So you almost, it was a convincing and a comprehensive talk. And I think with that, there is a definite place for urate lowering therapy in our patient cohort. Now, as you correctly said, in 2012, probably the world community in nephrology went wrong by looking at, or by interpreting or using the wrong data. For example, another example we have done, in 2012 guidelines, even the place for basilism have been transplanted. There's a lot of controversies, and I gave that talk in Bangladesh a couple of weeks back. So probably this 10-year-old guideline is not giving us the correct guidance as per today. So with new data coming up, I think we have to look into the, careful look into restarting urate lowering therapy in our patients. So in our practice in Sri Lanka, we don't have our guidelines as yet. It's great to see that Pakistan is doing a wonderful service by putting a lot of heads together and coming up with the guidelines. So in Sri Lanka, our practice for asymptomatic hyperuricemia, the controversial area would be uric acid value more than 8 in a male or 7 in a female. We would be doing the lifestyle modification first. For example, ask it to hydrate well. If we can put the patient on a uric drug like losartan, we would start on that and modifying the diet, asking for a low urine diet. And finally, we will do all these things and stop probably hydrochlorothiazide and diuretics. Try for a couple of months until the uric acid comes down. If not, we would be thinking of starting either allopurinol or febuxostat. That's our practice at the moment. Yep.
Thank you so much, Dr. Radhanpala. It was a wonderful session by both of you. There's no question in the chat box, I think, but I can say to the audience that this recording will be available on the YouTube. And if you want to comment anything there, and if you want to ask any question, you can ask the YouTube link. Very soon we will put this whole conference on YouTube, and anyone can see and revise the whole session again if they want to revisit it. Yes, Dr. Austin, please.
I just want to make a comment, if I might. I know you're probably running out of time, but just to Dr. Odana's a comment. I mean, you're so right. I think we have to have guidelines, that are developed within our own country, based on the prevailing landscape and the healthcare, armaments we have for dealing with. So in many countries, dialysis can be a luxury because it may not be available. Transplantation rates might be low. So we need to do everything in our power to protect kidneys. We absolutely do. And I think you're right. We probably have, I don't want to say missed the boat, that would be incorrect, but we haven't given uric acid its attention that it deserves for many, many years. We've done a lot of good things, and I'm actually, I applaud what you're doing in Sri Lanka, that you have thresholds for uric, well, you're screening for it, number one, because if you don't test for it, you'll never know they have hyperuricemia. But virtually every patient with progressive CKD will have elevation of uric acid, because the kidney is the predominant excretor for uric acid, as you know. And you're moving in with lifestyle, and then you're intervening. I think this is key, and I think in Sri Lanka, in Pakistan, in Ireland, we need to be moving in the same direction to try and protect kidneys, slow the rates of progression, and reduce the need for dialysis. So I applaud you in what you're doing, Dr. Odana.
Thank you, Dr. Austin. Thank you.
Thank you, Dr. Austin. Today we had a good session, evidence-based scientific discussion also. And we are also looking forward for the local data and formation of the guidelines based on the local data here in Pakistan. Today, by coming to the end of our session, I would like to pay thanks to all our honorable speakers and guests for joining us for this worthy cause. And we are truly gratified. And with your support, we'll continue to ensure the health of millions of lives. Let's continue pursuing shared vision of promoting a healthier society. Thank you all. With this, I formally end this session. Thanks. Thank you. Allah Hafiz.
Thank you.
Thank you very much. Thank you.
Thank you.
Thank you very much.
Bye-bye now. Bye-bye now.